Dave Matera, stand up, would you, so that they know who's here, Dave. He's from Essex, Connecticut, University of Compounding and Specialty Urologicals, pioneered in urology community for 13 years, educating over 11,000 patients on the non-surgical treatment for erectile dysfunction. He's a physician liaison and director of sales and marketing for University Compounding Pharmacy. Okay, so he'll speak a little bit about what his expertise is on. And then we have Peter Shorts. Mr. Shorts there, he's the Senior Territorial Manager with American Medical System, AMS, a 40-year-old company that provides permanent solutions for male and female pelvic health. He's worked with urologists in and out of the operating room for the past 8 years in Orange County and in the Inland Empire. And the first speaker tonight will be Dr. William Pearce. I was able to secure the CV for Dr. Pearce and was very impressed with some of the highlights, which I would like to pass on to you. And it's just the highlights. It's multifaceted. There's a lot more that I'm not going to tell you, but I just want to hit some of the highlights. From 2007 to the present, Dr. Pearce is the chair of the Urologic Oncology Tumor Board at St. Joseph's Hospital. From 2008 to 2010, Dr. Pearce was the president of the Orange County Urological Society. Dr. Pearce was awarded the Orange County Medical Association Physician of Excellence in Urology in both 2011 and 2012. From the beginning of his career, Dr. Pearce has achieved excellence in all his endeavors. He received an honors senior thesis at the University of California, Berkeley, and graduated with highest honors in 1992. He was a student delegate at the American College of Surgeons in 1996. He was awarded Dean Scholar, USC Medical School, 1995 to 1997. Graduated with highest distinction, USC Medical School, 1997. Alpha Omega, Alpha National Honor Society, USC Medical School, 1997. As you can tell, we have some very experienced presenters for you tonight. And I am going to start out with Dr. William Pearce, who has all these marvelous credentials. And it's a great pleasure that the Prostate Forum of Orange County tonight presents to you Dr. William Pearce, Dave Matera, and Peter Shorts, all speaking to you tonight. And if I can bring Dr. William Pearce up here, give it up for our renowned doctor.
Well, that was a very kind introduction indeed. This is my first time at the Prostate Cancer Forum here in Fullerton, but I'd like to compliment you all. I'd like to compliment you all on the wonderful job that you've been doing over the years. I've sent many patients here myself. My practice is in the Santa Ana area near St. Joseph Hospital. And I think now more than ever with prostate cancer, times are becoming even more confusing for patients. And it's important now more than ever to have groups like this to help patients make decisions on treatment, on possible complications with treatment, risks and benefits, and then manage side effects from treatment. So I agree completely that we can't lose sight of these groups, especially with all the information being disseminated. And these are really anchoring points for patients to negotiate their way through a very confusing landscape that's becoming even more confusing as the years go on. So again, I would like to thank all of you for having me here tonight, and I'd like to say a few words on one of the topics that is often a side effect or perhaps a complication from treatment of prostate cancer, and that is urinary incontinence, which can be a devastating problem for patient, spouse, and relatives that are involved with this. So, to begin, we'll just give you a brief definition of urinary incontinence. Most patients know when they leak. It's not something that we need to do a lot of fancy tests to figure out. It's something that the patient will tell you. And this is a definition. It's an involuntary loss of urine. I don't think that there's a lot of confusion about what incontinence is. Now, there are a few different types of urinary incontinence. We'll go into that later. But you could describe it as having a faulty washer. There are a couple different types here. Stress incontinence is really the one we're focusing on with the treatment of prostate cancer, because after surgery and sometimes radiation, we have problems with the urinary sphincter in the male that is responsible for the voluntary control of urination. Urge incontinence is another type of incontinence seen a little bit less frequently. Sometimes we see it after radiation, and that is leakage associated with someone having to go to the restroom right away and not being able to voluntarily hold that urine back. Mixed incontinence is a mixture of both. But again, I stress in this lecture we're dealing mainly with what's called stress urinary incontinence. So this is the type of leakage that men will get sometimes after surgery or even after radiation, where maybe you'll be sitting in a chair, get up from the chair, and you feel that urine trying to make its way out, and sometimes you can control it and sometimes you can't. And sometimes you have to wear pads, especially if you're an active person. Men that like to golf, sometimes it happens just when you swing a golf club or that tennis racket. But it's usually some sort of physical activity that puts a little bit of extra pressure on the bladder, and then that urine leaks out. So the process, of course, of holding urine is performed by the bladder, and the process of keeping the urine in the bladder is dependent upon the urinary sphincter in the male. The urinary sphincter is intimately involved with the prostate. It actually has fibers that go up into the prostate, and it's right at the very edge of the prostate. It wraps around the urethra and acts like a valve that keeps the urine in. So treatments for prostate cancer, surgery and whatnot, often can damage the sphincter muscle or weaken it. And sometimes that leads to urinary incontinence. So these are some of the reasons prostate cancer surgery, although we've certainly gotten better at that with the robotic technique and so forth, urinary incontinence still does occur, and it's important that we know about the different ways to treat it, or in some cases live with it. Of course, the point of this lecture is to give you some education on ways that we might be able to cure urinary incontinence for the prostate cancer patient. But I don't want to neglect the fact that we have some nice DVDs here on how you can live with urinary incontinence and make your life more comfortable. So this isn't something that has to be cured, but if you're the type of patient that wants to have it cured, these are some of the options that I'd like to go over. So it's a big problem. This is 55 million men in the world. A lot of these are not prostate cancer patients, but this just gives you an idea of the volume of the problem. Now, why treat incontinence? I think for most men it's a personal decision. But I can tell you that urinary incontinence can be devastating. I don't need to tell some of you how devastating it can be. It can cause embarrassment, discomfort. Patients feel uncomfortable interacting with family members. I had a grandfather who was so devastated by the incontinence, he didn't want to play. That's not me. He was embarrassed to play with his grandchildren and get down and play with them on the floor because he was afraid he would have an accident in front of them. So that's just one example of how incontinence can make people feel and make them feel insecure and take away and maybe even rob them of some of those precious moments in life that they would like to enjoy. And of course with intimacy, that can be a problem. If you're potent and want to enjoy a sexual relationship with your partner, which we all do, the leakage of urine can be embarrassing and make that sometimes impossible to do. Beyond those reasons, it's rather expensive. As if anyone has had to buy pads, you know that they're not exactly cheap. In fact, many of the Walgreens and CVS aisles make quite a bit of money on selling these pads, and it's one of their bigger ticket items in some cases. If you want to travel or go on vacation, it's not exactly exciting to have to pack a whole suitcase full of diapers just to go on that cruise. So we know that these are big issues for some people. These are just some other factors: the laundry, the expense. It can also irritate the skin. Urine is toxic, acidic, can cause problems with the skin around the genitalia. So again, we're talking a little bit more about the causes here, and I'm not going to go over them too much because we're a more focused group. We're talking about prostate cancer patients, so I think we're going to skip that. Medications, I want to mention that briefly. For most prostate cancer patients, those that have had treatment and suffer incontinence, medications are usually not very effective. They can help to some degree, but this is really, we're dealing with a structural problem with the urinary sphincter. And most of the time, medications, they can help a little bit, they can alleviate some of the urinary frequency, but they're usually not a cure. These are pads, different types of pads. I think this sort of issue is probably going to be addressed in the DVD, so I'm going to skip over that a little bit. This may or may not be in the video as well. This is just an external clamp, which sort of acts like a bear trap, if you want to think about it that way. The penis goes through there, and then that clamp goes over the penis. Can you all hear me okay? Okay. And then catheters. If any of you have had prostate cancer treatment, you probably know what is called a Foley catheter or an indwelling catheter. It's a tube that goes in through the penis and drains the bladder internally. And then most of you may or may not know that there's also an external catheter, which is sometimes called a Texas catheter or a condom catheter, and that fits on the outside of the penis. But again, these are just external devices. We do have some success in treating patients, for example, after a radical prostatectomy with incontinence, by doing biofeedback or pelvic floor strengthening muscles. Exercises such as, maybe you've heard of the Kegel exercises, that strengthen the pelvic floor and try to build up the sphincter muscle or residual sphincter muscle that might be left after treatment. So that's actually a very effective way, but it oftentimes won't get patients completely dry. People find themselves changing their behaviors to compensate for incontinence. This is an example of some biofeedback. You may read about bulking agents. This is a type of therapy where the urologist will inject some material, look inside the urethra with a device called a cystoscope, and actually inject some material around the sphincter muscle of the urethra in order to try to bulk it up so that hopefully that would stem the flow of urine. I must say I'm not a big proponent of this. It doesn't seem to work very often. I'd be happy to talk to more of you about it in the question and answer session, but I'm going to kind of skip this for now. I just don't think that they're very effective. These procedures are what I'm going to talk about next. And these are all surgical procedures that are very effective in controlling or curing stress urinary incontinence after prostate cancer treatment. The two in the top part of the slide are called male slings, and the third one is the artificial urinary sphincter. So Those of us that do a fair number of these procedures and have experience with them know that it depends on the level of continence that a patient has or exactly how much they're leaking in terms of which procedure will work best for a given patient. Patients that tend to leak 1 to 3 pads a day, we consider that to be mild stress urinary incontinence, although still that's a big problem for a patient most of the time, would be a candidate for something called the male sling. And people that leak more than that, we usually recommend placing what's called the artificial urinary sphincter. So this is what we know today to be more of the modern male sling. It is an outpatient procedure in general. It works immediately to restore continence, and it's something that you won't have to operate as a patient. It sits in the urethra, it supports the urethra, and it's a device that's hidden inside the body. The mechanism behind it is we restore the support underneath the urethra that's lost in the case of radical prostatectomy. This is an example of the male pelvis, and this is the urethra, the structure here. These are some of the muscles around the urethra, and the sling is placed through a small incision on either side of the pubic bone and threaded through this part of the pelvis and then around the male urethra and gently tightened. This is done under general anesthesia or spinal anesthesia. Now that's a successful procedure, but again, it's important to note you have to go to someone who has some experience with the procedure and someone who knows which type of patient would benefit from that. Because if you do the wrong operation for the patient, if it's not the right fit, you're not going to get a good result. Now this is the gold standard of treatment called artificial urinary sphincter. It's actually been around since the 1970s, and we use this device for patients who have relatively heavy leakage, and that would be usually 3 or more pads a day. It is either an outpatient or an inpatient procedure. The operative time is about an hour, plus or minus, and the patient satisfaction rate is extremely high. According to the numbers from AMS, medical systems, 92% of patients would have the device placed again, and 96% would recommend it to a friend. Now, I think those numbers are very accurate in my practice as well. Some of the happiest patients I have, and I do all sorts of types of surgeries, are the patients that you restore their urinary incontinence. I mean, you really end up giving a lot of these patients their life back. And most of them, I can't think of one that hasn't been extremely happy with the device. So you would have to see a urologist to talk about these issues, of course. And it's important to choose someone, again, who has some experience with it. And just to review, we have lots of different ways of managing incontinence and treating it. And it's important to sort of think about those issues, if they make sense for you, and if you want treatment or not. And that's always a personal decision. But I hope this provided a little bit of education in what we do to try and control urinary incontinence. Now, I think we're going to wait until the final speaker has finished before we take questions. Is that correct?
Yeah, after all the speakers are finished, then we will line can you hear me? Okay. After the speakers are finished, come on up here and we'll take you in order of you appear in line to ask any specific question of any speaker that we have here.
Okay, well, thank you all very much, and I'm going to enjoy listening to the next two speakers.
Let me have that. Yeah, that's a lot better than this one, Carlton, for some reason. Okay, which one of you guys are next? They're fighting over that. Okay, looks like Pete Shorts wins. Can you imagine that name, Pete Shorts? How many times have you ever been ridiculed for that, huh?
Exactly. You're the fifth one today.
I'm the fifth one today. I guess I got a tap dance up here while he's getting ready to go. Are you good to go?
Yeah.
Okay. Here, I'll give you the good mic.
Thank you, Russ. And done a couple things here before with your group, and it's always great to be able to come out and see you folks, and appreciate the opportunity to pass along some education about what AMS does and some of our products, and to just kind of echo what Dr. Pearce said earlier as far as treatment for incontinence. Not to give him any more accolades than he already has with his background, but as far as surgeons I've worked with here locally in Orange County and Inland Empire, he has more experience with treating patients with surgical devices for incontinence than any other urologist in the area that I've worked with over the last 5 or 6 years. So he'll be a great one to ask any questions to regarding that stuff, as well as the ED stuff when we're done. But let me just, I don't want to, I'm kind of going to touch on briefly some of the things in regards to erectile dysfunction. I'm going to let my cohort here, Dave, talk about non-surgical treatments for erectile dysfunction, and I'll just kind of get right into the surgical side of things. It's usually the other way, but since our slide presentations are kind of set up, so I'll do that. Treatment, ED is very common, especially over the last, since '97, since Viagra came out. It's certainly been a well-advertised issue on TV and talked about in magazines and newspapers. So it's very common. 30 million men, 90% physical, only 10% psychological, and it's probably even less than that psychological when you look at the reasons. Physical causes of AD, there's many, but obviously the prostate cancer group is certainly surgical or radiation or what have you are issues, and compiled with that blood flow regarding heart disease and diabetes certainly contribute to that. And you have cardiovascular disease, bad blood flow, diabetes, affects the blood flow to the penis as well as other portions of your body, certainly are major causes for ED. Of course, you don't have to live with it. That's why we're here to talk about different treatment options. I'll breeze through these slides and just kind of get to the penile implant side and let Dave talk about specifics of the oral medications, vacuum devices, injection therapy. Actually, I can touch briefly on oral medications. I used to work for Bayer Pharmaceutical, who sold Levitra years ago, so they still do, and talk about oral meds. Those medications are just basically for improving erections, okay? They're not going to take you from nothing to 21 again. They work on a certain enzyme in your body, but you have to have good blood flow for it to work. You have to have good nerve conduction for those things to work. And if you don't have everything all going on, and you haven't had a big high-fat dinner and drank a bottle of wine, then things may happen with those drugs. But so they do work, but there is a high percentage of patients where they don't work. This is a study talking about overall patient satisfaction with ED treatments, and it compares the penile implant with oral medications, and Viagra was actually the medication in the study, and then penile injection therapy. And so, just to give a little background to this study, these were patients, over 100 patients that presented to a urologist. Say, for example, 100 patients walked into Dr. Pearce's office over the next 6 or 8 months seeking treatment for ED. What the urologist did is started everybody out on 50 milligrams or 100 milligrams of Viagra, whether they had been on it before or not. Instructed them how to take it on an empty stomach or, not drinking a lot of alcohol, and so on and so forth, and correct instruction. Now, if the patient tried multiple trials of that and it didn't work, then Dr. Pearce would offer them either injection therapy or vacuum device. They tried that therapy. Some of it worked great on it. They continued on, they were happy. If that didn't work, then Dr. Pearce would offer them a penile implant. And if they went forward and we had a penile implant, then after all these things, they tested their overall satisfaction rates. And the penile implant came out on top as with 93% compared to oral medication, 50% penile injection therapy. Not to say those other things don't work, which they did on many patients, but overall in the end, the implants won out. And certainly you're going to do the same protocol that they did in the study. Most physicians will, including Dr. Pearce, who started somebody out on a more moderate therapy before even talking about implant. Regarding the implants, they've been on the market for over 30 years. In fact, the person who started American Medical Systems, Dr. Bradley Scott, was the one who invented the inflatable penile implant, as well as the artificial urinary sphincter. So our company is just focused on male and female pelvic health. That's all we do is urological and gynecological devices. There's around 25,000 of these implants implanted every year. The slide's a little bit old. I'm sure there's more like 500,000 implants done over the last number of years. Just to break down, there's 3 different kinds of implants, penile implants. One is a non-piece inflatable, one is a 2-piece inflatable, and one is a 3-piece inflatable. And I'll explain the differences between those. The 1-piece non-inflatable are just basically 2 semi-rigid bendable rods that are inserted into the 2 channels within the penis. And the type of patient that might be good for is someone who doesn't have good manual dexterity, somebody who wants something simple, less parts, less chance of malfunction or breakdown. And so these 2 cylinders are totally concealed within the body. It's a simple surgical procedure, but it always stays a little bit firm. And it's like you were when you were in junior high. When the teacher asks you to go up to the board, you really want to get up. It's always a little bit firm, and they should show through some clothing. If you are used to wearing sweatpants to the swap meet or wearing those floppy shorts at the beach, you may want to get a little something more tight-fitting. But it works well. Lots of patients are very satisfied with them, and they work well. The 2-piece inflatable implant is kind of in between a 1-piece and 3-piece. There's 2 cylinders that go in the penis. There's a little pump that goes in the scrotum, and everything's filled with saline. So when you want to use the device, you find that little pump, you squeeze it only 3 or 4 times. It transfers fluid from the back. Come up here, walk you through it. It transfers fluid from the back of this up to the front. The cylinders get very rigid, and you can keep it up as long as you want to keep it up. When you're done, you actually simply bend the penis at a 90-degree angle, which creates pressure in the cylinders, and the fluid kind of flows in the back, and the penis and the cylinders become flaccid. This requires a little bit more manual dexterity, and because it is a silicone device filled with saline, there is a possibility of leakage, and the flaccidity is, there's still a little bit of fluid in the cylinder, so it's not as natural as what a 3-piece implant is, but it's quick, relatively quick and easy to implant, and patients have very high patient satisfaction as well as partner satisfaction with these devices as well. All these devices have well into the mid-90 percentiles of patient and partner satisfaction. Oh, that'd be great. All right, so this is, oh, this is it.
Sorry about that. Underneath, you got it?
Oh, it's right.
Trigger mechanism underneath.
I wanted to go back to,
See here? Go back, yeah.
go back to the slide.
That's it. Back. Why is it not working? Now, this was working normally, right?
It was, yeah.
And then I stepped up?
Yeah. Okay, well. All right.
See if it works now whenever you have a chance.
Okay. We can skip the X-rated. There's no kids here tonight, but we can go into this. But these are the. This is the. Oops, these are the advantages and disadvantages of the three-piece penile implant. Actually feels more like a natural erection. It mimics exactly what the body does. There's two cylinders that are. No, I'm just going to point. Again, there's two silicone cylinders placed in the penis. There's a pump in the scrotum, and this one has a little reservoir up underneath the fascia in the abdomen, where and everything is concealed. You can't see anything. You can't feel it. Fluid stays there. When you want to use the device, you pump it. Transfers fluid from this reservoir into the cylinders. They get very rigid as any erection you've ever had. And it stays up as long as you want it to stay up. And when you're done, there's a little button on the pump. You press it, the cylinders deflate, and everything goes, all the fluid goes back into the little reservoir. Very high satisfaction rates. It's very soft. When it's not being used, nobody would ever tell you to have it unless you told them. But the disadvantages again, there does require some manual dexterity to pump the pump. There's a possibility of leakage malfunction, as with any device. And the possibility of unintentional erections is really shouldn't be on here anymore because there's a lockout valve in the pump to negate that. This is just someone's volunteered themselves. They have a live picture of what it looks like. Patient finding the pump in their scrotum and then squeezing it and pumping it up, and they get an erection. This is the same type view from a side view. These implants are designed to last a lifetime. The survivability of the penile implants has better data than hips, knees, pacemakers, any other implantable device. They've been around a long time, they've been perfected. Not to say that they don't have malfunctions or breakdowns from time to time, but overall they're built to last a lifetime, and they usually do. Again, this is just some data with clinical trials talking about who would recommend it to others. They also looked at the partner satisfaction, and this is a study that was done where partners were actually separated. So it's not like the husband's sitting there and they asked the wife, "How was it?" "Oh, great, the best ever." They separated, but it's a well-done trial with the partner satisfaction as well. So these work. They certainly are an option, and they are certainly, if the other alternatives, which Dave's going to talk about here shortly, don't work out, there's always hope. And the implants have been around a long time. They work well, and there's excellent surgeons like Dr. Pearce in the community that do a very good job with these things. So with that, I think I'll pass it along to Dave.
Okay, well, thank you so much, you guys, for allowing us to come to the group. It's such a privilege to be here, and hopefully we're able to share just a little bit of information that you may know or may not already know. But the topic of erectile dysfunction is something that so many people are interested in talking about. As in, years ago, people kind of swept it under their carpet sort of thing, and it wasn't discussed, but really nowadays it's a couple's approach. And that's what we encourage you to talk to your partner, talk to your wife about it, because it's nothing to be embarrassed about. If you look at the number here, 30 million men suffer from erectile dysfunction. That's a lot of people. So it could be your neighbor, your brother, it could be a close friend of yours that's suffering from it, that's afraid to talk to his doctor. And as Dr. Pearce said, and Pete said as well, we encourage you to go see your urologist, because really they're the specialist on erectile dysfunction. I'm going to talk about the non-surgical treatments. Obviously, Pete already talked about the surgical side. Treating erectile dysfunction can really enhance your life and your relationship. There's Dr. Erwin Goldstein out of San Diego that gives lectures all the time on erectile dysfunction as well. And he always states to his audience and to his patients that it's really a couple's approach. And couples who are having vaginal intercourse, is how they rate it, vaginal intercourse, have a closer relationship. The studies prove it. There's certain things that can cause erectile dysfunction. High blood pressure. Pete talked about a few of these, but high blood pressure, diabetes, an injury, spinal cord injury, and of course what we're focusing on here tonight is prostate cancer. For those who've had a radical prostatectomy or the removal of our prostate, now that the surgical techniques that Dr. Pearce and other urologists are involved in is saving those nerves that are responsible for an erection. So there's two bundles of nerves around the prostate that surround the prostate. You can kind of see them in this picture here, that they kind of peel off the prostate before the prostate is removed. And that's called a nerve-sparing radical prostatectomy. So if they were able to save those nerves with these new techniques of surgery, and some of you I'm sure have heard about the robotic surgeries and these other techniques that are available, you're able to restore the erectile function again by sparing those nerves. Vascular disease, there's many cases that are associated with hypertension, high cholesterol, cardiac disease, smoking, poor blood circulation, and then there's a psychogenic aspect of erectile dysfunction too. I think this is something that all men experience at some point in their life. There's a point when they're not able to perform. It doesn't necessarily mean it's a medical condition. It can just be due to a psychological thought. Maybe they're not comfortable with their partner, they're not familiar with the love-making activities with that specific female or significant other. So, PDE5 inhibitors. All of us have heard about Super Bowl and the Viagra commercials, the Cialis, Levitra, all these pills that are available, but the pills don't always work. And you know what? That can be really discouraging for us as men, because we're supposed to be able to perform. Just knowing that we can perform, it holds a psychological factor for us. But the problem is, the pills don't work for everyone. There's contraindications that are associated with using the pills. If you're on nitrates or alpha blockers, it's not recommended that you're going to be using these pills. And there's also precautions with getting an erection and the erection lasting too long, and that's called priapism. So if the erection is lasting 4 hours or longer, then there's the danger zone. Although it may sound like something exciting, having an erection for 4 hours, the fact is that it's not recommended. So you have to manage the pills properly with your doctor and talk to him, and he'll mention to you about the vision changes, the blue vision, headache, flushing, nausea, diarrhea, all these things. I mean, if my wife has a headache, we're not having intercourse, right? Well, it's the same thing for a man, you know. If he has all these aspects of side effects, we try to tough it out, you know. But the fact is that can really interfere in the sexual relationship. Pete mentioned no fatty foods or alcohol, and that kind of kills the moment because, you know, when you go out to dinner, you have a nice bottle of wine with your wife, and suddenly you come home and you're prepared with Viagra, and you're not having a good result. That can be really discouraging. Oh, I popped this slide in here. This is another side effect of Viagra. It says, hey, lover boy, you dropped the Viagra on the floor again. And obviously the dog ate it, so there's a little bit of humor there for you. So that's something you got to be careful with, right? It looks like it worked for the dog, but not the guy sitting on the bed back there. I don't know. Trimix. Well, when I first learned about a penile injection, I thought to myself, I've never had a dream of inserting a needle in my penis. That's not something really too comfortable to think about. But when I educated myself on how easy it is to use a penile injection, I was quite surprised. Because, you know, you go to the doctor, you get your blood drawn, and you think, wow, you know, it's always an uncomfortable conversation with your doctor. And it probably has been since we were children, right? You know, going to get our blood drawn or getting a shot at the doctor. But the size of this needle that goes into the base of the penis is very, very small. It's a diabetic needle. It's a 31 gauge. It's just about the smallest needle that's on the market that can be injected into the tissue without breaking. So 29, 30, 31 gauge needle, that's the size. So what we do is, the simplest way to explain it is like a liquid Viagra. Viagra, when you take the pill, it has to go through your entire systemic process for it to work. You have those side effects. Now we take this vasodilator, this Trimix, our penile injection, and we insert it right into the base of the penis. Well, if you think of the penis, the most sensitive part of the penis is the glands of the penis, which is the head of the penis. As you can see in the picture there, this is the head of the penis. But toward the base, there's a low density of nerves in that area. So therefore, it's well tolerated. It's kind of like the earlobe, is how I like to explain it. It's like the earlobe. You know, getting your ear pierced, you know, it's well tolerated. Millions of people do it. And it's the same thing with a penile injection. If you sit down with your urologist, he'll explain to you how to do the first injection. So it's going to take that fear away. And the fact is that within about 5 to 15 minutes, you're going to be able to experience an erection. How long does it last? Well, most patients are able to experience an erection for about an hour. It stays localized in the penis, so therefore you're not going to have all those systemic side effects that are associated. So, you know, the headaches, the nausea, most likely you won't have those sort of side effects. And the cost, in comparison, the average cost of a penile injection is $6. You know the average cost of an erection pill like Viagra? Does anyone know? $10 is more than that. $20. So depending on where you go, now you can get it from Canada. Now people from, you know, third world countries are basically breaking our barrier, trying to sell us pills. You probably see it on the internet. You get emails from all sorts of places around the globe trying to, you know, get these sugar pills or other sort of pills similar to Viagra. It's become a big marketing ploy, is my point. So the cost aspect is very reasonable compared to the pill. It's about $6 an injection. Maybe some of you have heard of the name Caberject. That's a name brand of a penile injection. And basically, with Trimix, the word tri is 3, so it's 3 ingredients that we're injecting into the penis. And the advantage of these 3 ingredients is that we're able to monitor and control the dosing. So when you go to your doctor and you get a penile injection, most likely you're not going to get a perfect erection the first time because it's dosing, right? So we start at a low dose and we titrate up until the dosing is just perfect for you. So there's no one cookie cutter dosing for every patient. It's different. Contraindications, sickle cell anemia, penile implants, side effects, bruising, priapism. These are important side effects that you need to discuss with your doctor. If you don't know how to do a penile injection, don't do it on your own the first time. Don't go to one of the male clinics that are pushing these penile injections upon their patients. Talk to an expert. I mean, you heard the credentials of Dr. Pearce. He knows the dynamics of the erectile function. So by talking to a urologist, you're going to get that expert opinion. It's worth the money. If you don't have the coverage through your insurance, it's worth the money to go talk to an expert. That about covered the penile injection. Now I want to talk to you about this vacuum therapy system. Has anyone heard of a vacuum pump before? Yeah, so a good portion of you have. You know, when I first saw one of these vacuum devices, I thought to myself, you know, is this a sex toy, or what is this? You know, is it really something that could be incorporated in the bedroom? And you know what? In magazines and movies, you know, people have really been uneducated on a vacuum device and the efficacy of it, how effective it really is. I brought a sample of a vacuum device here today, and I'm going to show it to you in a minute. The model that we carry out of our facility is not a sex toy. It's something that's FDA approved. It's covered by Medicare. If you have Medicare as your primary, you'll be covered for a vacuum device. The great thing about it is that it's non-invasive. There's minimal side effects. I saw someone laughing. If you're on a Medicare plan that's an HMO or something, it's not going to be covered, but most insurance groups do cover the vacuum device. But the fact is, it's not a sex toy, and I'm going to show you how it works right here. It has the fewest reported side effects. There are 6 things that I listed here that I think that are important when you choose any therapy. That is predictable. If you're using a penile implant, you know it's predictable. The penile implant is controllable, and it's often safe. And you know, with a vacuum device, you can get an instant erection. And the effectiveness is over 90%, and the cost, if you do have a cost that's associated, it's usually about $500 for a device. They range between $300 and $500 depending on what model you want. You know, you can get it battery operated or manually operated. There's different models that are out there, but you want to get one that's prescription. So you know this is a controlled device, and you're not going to hurt yourself. I mean, we had a patient that came into a urologist that I was working with that used a vacuum cleaner, and he applied it to himself. See, the concept was there, but he just wasn't educated on the damage. And unfortunately, he'll never have an erection again using a vacuum device because it was such severe damage. So, moving on to the next slide here. The advantages I mentioned is non-surgical, it's FDA approved, prescription. I mentioned the cost. You know what I really respect about a vacuum device is that there's a psychological element with using it. If you're using a pill and you're only having 70% results or 80%, or sometimes it works and sometimes it doesn't, or there's side effects that you have, then using it as an adjunct will really help to build your confidence, because you know that every time that you're going to be engaged in intercourse with your partner, you'll be able to perform. And that's what every guy wants. Disadvantage, there can be some bruising that takes place. If you're on a blood thinner like Coumadin, for an example, you really want to be careful with using a vacuum device. It really can cause some petechiae, which is basically bruising. Another disadvantage is that we're drawing blood into the penis, and I'm going to show you how it works in a second, but we're drawing blood into the penis and trapping it there, and oftentimes the penis gets a little bit cool. So that's a disadvantage for sure. And having a willing and supportive partner, isn't that 90% of it for us? If our partner, if you get a vacuum device from from your doctor has prescribed it for you, and you go home and you haven't been sexually active for 5 years or 10 years, and all of a sudden you have an erection and your wife's not prepared, then it can be a real catastrophe, right? So it's something that needs to be discussed with your partner. Combination therapies, I touched on that very briefly on the VED, the vacuum device. It can be used in combination with one of the PDE5 inhibitors or the pills that we discussed. There's also a urethral suppository that's called USE. This is basically a prostadyl that a patient will insert a little pellet down into the urethra, and this pellet will dissolve and therefore stimulate an erection. And so the medication is absorbed into the penis, and usually takes about 15 to 20 minutes for that to work. So that can be used in combination with a vacuum device, and ICI therapy is the injection therapy that we talked about. Okay, so here's the model here. I hope I'm not blocking anyone's view here, but you can see that the patient will place his penis inside of a cylinder. Negative pressure is created throughout the cylinder, and negative pressure on any part of your body increases blood flow. So with the penis, it's like a sponge. Absorbing all that blood into the corporal chambers of the penis is what's going to enable a man to experience an erection. So whether he's stimulated or not, he's going to be able to experience an erection using this device. So he'll place himself inside here, he'll hit a battery-operated button or a manually operated pump, squeeze a lever or hit a button, and it'll draw blood into the penis. Okay? So for a radical prostatectomy, many surgeons are now saying that we would like you to start using a vacuum device for therapy to get rich oxygenated blood throughout the penis and therefore recover those nocturnal or nighttime erections again. So they're trying to, by means of penile rehabilitation, get the blood circulating again. And so I have the studies. When I quote a study, I had to have the paperwork. So I have the studies, and I'll have it on the back counter so you guys can read the articles that show that using a vacuum device following or post-radical prostatectomy will help to shorten the recovery period of a natural erection. So if you've had a prostate removal, it's something you can talk to your doctor about and see if he can discuss that with you and have some good results. I put a slide dedicated for the benefit of the urology specialist. I know I touched on this briefly, but I'm going to mention it again because it's really, really important. There's so many men that have gone to their primary care physician, that have gone to these male clinics around the country. You ever heard of Boston Medical Group? Okay, and you've heard the male clinic. I'm not trying to knock any of the clinics, but a lot of these clinics do not have the support system needed to treat erectile dysfunction. And what do I mean by that? The support system, they don't have the experts, such as Dr. Pearce and other urologists in your area that are qualified to really to treat this. It may be a simple thing as low T, right? Low testosterone. If you've gone to your primary care physician and he has just given you Viagra, but he hasn't checked your blood levels, he hasn't done these panels, it's really discouraging for the patient because he's not always just going to respond to taking a Viagra pill. It could be something so simple as taking a testosterone shot or a gel that they have and applying it daily and bringing those testosterone levels back up again to be able to attain an erection. Your urologist is not selling drugs out of his office, and that's what a lot of these male clinics do, is they're just trying to push one specific profitable item. And I mean, a lot of these clinics are successful doing that. I mentioned that it's a couple's approach. Speaking with your wife, maybe her testosterone is low as well. You know, women's testosterone levels change earlier than men. So our number one selling drug out of our facility is testosterone. And if you were to guess, would it be for men or would it be for women? What would you say? Anybody? Most people say men, but it's actually women. Our number one selling drug is testosterone for women. And it's a much, much lower dose, but it's something that needs to be controlled. And you know what? Women have a lack of desire as well when it comes to the association of intercourse and testosterone. If her levels are low, they can be easily managed, and suddenly she can start regaining that desire that she had years ago. Something to talk to your doctor about. Let's see here. I mentioned here, we treat the cause and the condition. So there are specialists who do treat the cause and the condition. That's really, really important. And you know what, nowadays, I've only been in the business of urological products for 13 years. I'm not a doctor. I'm not proclaiming to be a doctor. We do encourage patients to do their homework, and you know what, nowadays, I'm amazed with how many people are doing their homework. When I give someone a study, usually they take it home and they read it, and they come back and start asking questions. But you know what, the beautiful thing is about doing your homework about erectile dysfunction is that you're now more qualified to ask the right questions. Nowadays, doctors are limited to having a certain amount of time in the office. And, if you have 15 minutes or 30 minutes with your doctor, you don't want to ask elementary questions that you could have done the homework on your own. You want to go in there with qualified questions, and therefore you get qualified answers. And you can easily go through these treatment options and come out of the office feeling more confident and trying these out and having better results. You see my point? So it's really important that you read the literature. I have brochures here. Pete has his brochures as well. And read them, reference the studies, question it, challenge it, and you'll have better results. I have DVDs as well. I think Pete does also. This DVD explains all the non-surgical treatments for erectile dysfunction. It's from a urologist standpoint, not my standpoint. It's a doctor's standpoint. And we have these brochures in the back, Pete and myself. We both have these brochures talking about all the non-surgical treatments and surgical treatments. So, do your homework on that. And when it comes to the question and answer part of this, I have a sample of a vacuum device that I want to show you. And I have a sample of a penile injection that I wanted to show you as well. But that's basically it for my presentation. Again, thank you. I can speak on behalf of Dr. Pearce and Pete. Thank you so much for this opportunity. It is really amazing to come and speak with you, and we're welcome to answer any questions or guide you in the right direction. If you don't have a urologist assigned to you, we can help you. We can help you through that process. So just allow us to do it. Thank you.
Don't step on that. Is it possible, and you don't want to do this now, can you demonstrate the vacuum device and the penile implant here?
Sure.
He mentioned the needle that you feel like you don't want to insert in your penis. I've done it before, guys. It's just a little prick.
Russell's penis that we can use for the demo.
Are there any volunteers? And I have to tell you this with all due respect. I mean, we're in a church, and I was thinking to myself, this is probably the only time I'm ever going to have a conversation about a penis in a church and get away with it. It's psychological. So, okay, so basically what this is here is, see, it's a bottle of medication, and out of this bottle, you draw out the medication and insert it in. There's no cookie cutter, and I know I kind of explained this already, but there's no cookie cutter formula. If you go to your doctor and Dr. A, Y, and Z gives you a formulation and you only have 50% results, you can't just put this down and say, hey, you know what, this is not going to work for me. Maybe it's not, but the fact is, if you had any result, any response using a penile injection, that's a pretty good indication that You can just dial in the dose, discuss it with your doctor, try not to get discouraged, talk to your partner about it. You know, it's a couple's approach. If you I mean, you guys know better than me. I'm sure you've been married for many years. Your wife is such a wonderful support system. That's like built in. I mean, money can't buy that. That's just an amazing thing. So your wife can help you through the process, and obviously, you know, being properly educated on how to inject. So usually this medication has to be refrigerated, okay? And you have a travel bag that you can take with you, so you can take it if you're going to Vegas or you're going out of the country, whatever the case. You'll just have to have a little ice pack that you can take with you. But this is is a 1 cc syringe with a very fine needle on the end of it. So it's not too cumbersome, right? It's just basically two things that you're going to have with you. Some alcohol swabs as well. As far as the vacuum device, I'm going to have to put the microphone down just for 1 second so I can put it together for you.
You know, I think after the Q&A session here, some of this information is very personal. And I'm sure there's a lot of you who don't want to come up here and ask a personal question in front of the whole group. So I'm going to ask the presenters tonight, after we're done with the Q&A, to just hang around a little bit, and if you want to come up and talk to them personally, I'm sure they'd be happy to do that. So we'll have a general Q&A, and then we'll have an informal, personal question and answer individually with the presenters here tonight.
Okay, thank you so much. So this is a sample of a vacuum device. I have a tube of lubricant in my hands. Lubricant is really essential for having a good seal with a vacuum device. What a patient will do is he'll just lubricate the end of the cylinder right here, okay? And he'll stand up, place his penis inside this cylinder, and he'll press this button. This one's battery operated, right? So it creates that negative pressure against the body, and it draws the blood, it absorbs the blood into the corporal chambers and allows a man to have that rigidity that he needs. You'll have a stronger erection than you've ever had in your life using a vacuum device, I guarantee it. Because your body naturally, you can take a Viagra pill and have a good result, but it's kind of like an air balloon. What do you do with a balloon before you blow it up? You want to stretch out the tissue, okay? It's the same thing with an air balloon. You stretch out the balloon, the latex, and it allows you to blow that air in very, very easily. So with a vacuum device, the rehabilitation aspect is really very well designed. What you can do is you can stand up, like I said, press the button, and don't just hold it down the whole time. Go in increments, allow the blood to gradually flow in. You know, and think about a natural erection. You don't just walk into the bedroom and you think about an erection and it comes right out. The blood has to gradually flow into the tissue to get that tumescence, that rigidity, that strength for intercourse, for penetration, okay? So gradually get an erection, and for the rehabilitation purposes, you know, the doctor will say get an erection and then release the pressure, but let the erection go back down, and repeat this process, and therefore address the penile atrophy that sets in. If a man's not having a regular erection, he's not waking up with the erection, or he had surgery, a lot of times this atrophy, this fibrosis can set in. So by stretching out the tissue and increasing rich oxygenated blood into the tissue, you're going to get that rigidity back. So what about maintaining the erection? So once he has an erection, he's going to quickly push this ring off onto the base of the penis, and that's going to maintain the blood flow inside of the tissue and allow that strength that's necessary for penetration. The ring has to be the right size. I tell the guys, start with the largest ring you can. They all laugh when I say that, but the reason why you start with a large ring is because for the most part, most patients are not the same size anatomy, so we want to start with a large one. And even with a larger or smaller anatomy, the ring, you can't just say, oh, you have a smaller anatomy, so I need a smaller ring. It's just really varies individually for each patient. So start with a large ring. The ring can stay on for 30 minutes. That's what's recommended. No longer than 30 minutes during intercourse, and he'll be able to perform during that time. and then he'll have to obviously take it off, let the blood recirculate, and he can use it again if he wants. But, obviously talk to your doctor about side effects with any risks and side effects with any of these treatments. I'm not recommending these treatments for you. These are just options. We want you to know what the options are from the expert standpoint, like Dr. Pearce and Pete and myself, who work with these products on a routine basis. So, with that being said, are we going to go to question and answer here?
Sure, we'll do question and answers right now. If anybody has any questions, just come on over here and line up here. Don't say your name, just the question. We don't want to advertise who you are. Just your question and who you want it to be addressed to, and we'll take it from there. Let me see here. These people are going the wrong way. John, you have a question?
I have a quick statement instead of a question here in regards to...
Can you hear him back there?
No.
Hold
Talk
it up
into
to
it.
him.
Okay, like this?
Yeah, you're soft-spoken
Talk into the
anyway.
end of it.
Okay. I have been incontinent for 7 years. I tried all kinds of things. I had surgery, laser surgery and so on, and it didn't work. And I found a way that it does work. In the last couple of years, I was able to be in the Swiss Alps. I was in France. I traveled throughout Europe, Canada, and yes, I do have a backpack, and it says on there embroidered medical equipment, and that is my supply. And I have it at home, and I use it, and it's by the front door. I live in an area that has earthquake and flood, so something I should have done for that, now it has helped me to focus this way. I've talked to men in South Africa that my son gave him my number while they were on a plane together going to Chicago, and the man was getting wet all the time and he was discouraged, and my son said, "You should talk to my dad. He knows a lot about this." So he gave my phone number, and 3 days later I get this phone call from South Africa, and it was the gentleman, and I was able to help him. He called me back later. It was working for him. It freed him. And having that freedom to do a lot of the things I wanted to do, this works. If you take one, limit it to one each so that we can have some for other groups that will come. Thank you.
I don't see anybody lining up here, so I guess this is a very personal session. Why don't I knock off the regular session, have anybody that would like to talk to any one of the three presenters personally go up and you can talk to them personally. In the meantime, before we do that, we at Prostate Forum operate on a very limited budget, as you can tell. So we can't afford to pay these presenters that come here. But next to money, the most important thing in a person's life is the time he has. That equates to money. So we have found a way to save these presenters time. We have a coffee cup here with Prostate Forum on it, and it fits in your holder in your car, so that you don't have to wait and drink your coffee at home. You can fix your coffee, put it in your car, and it's going to save you time. So we have one of these cups for each one of the presenters that are here. In addition to that, I have one more thing I'd like to say. Normally, I work with the Prostate Board to get these speakers here. And tonight, I would like to thank Dr. Marty Weissman right here, because he arranged for every one of these three speakers to get here. He's a urologist at St. Joe's, and he's also on our board of directors here at Prostate Forum. Thank you very much, Dr. Marty Weissman. Well, we got a question here. Bert has a question. Or maybe two.
I've been a user of Caverjack for a long time, and it's great. They took the self-contained mixer off the market, are any other sources of this stuff still on the market with a powder and liquid mixing injector?
Yeah, they took that off the market, so now it comes already mixed. So that's what I was talking about as far as the tri-mix or quad mix or the different mixes that are out there. There is a mixture called bi-mix that you do not have to refrigerate. I know that may be your concern, is that you have to refrigerate some of these other mixes. So this one, is the bi-mix, is just basically 2 ingredients, and so you don't have to refrigerate it, you can take it with you wherever you go.
That's basically what the old Caverject was. It not refrigerated for a period of time and it still worked fine.
Yeah.
And that's only one. It's a one mix, right? It only has one drug-in.
Yeah, basically prostaglandin D1.
And I never had any problems with that, so
So, you know, with these...
bi-mix probably would work fine.
Yeah, so the best thing to do is make an appointment, again, with your urologist, and he can put you on the proper mix and revisit that, because, yeah, there's been some restrictions with Caverject. There's certain side effects that you have with Caverject that you may not have with another mix, and also there's the cost that's associated with it as well.
Well, I was lucky my insurance company paid for Caverject,
Okay.
which it probably will not do for bi-mix or tri-mix.
Yeah, so you figure without insurance, about 40% of our patients are getting coverage for the compounded ingredients. So without insurance, it's going to be about $6 an injection. So, you know,
Medicare?
Medicare is not going to pay, but without insurance, it's going to be about $6 an injection, which, you know, Medicare doesn't pay for Viagra either. So if you figure, you know, $20 a pill versus, you know, just a fraction of that. So of course, I'm not recommending this treatment. Go and talk to your doctor, and he can go through this again. I mean, there's a couple of urologists here today. I don't see the opportunity, but there's been changes with Caverject, and that's why these other treatments are good options.
Well, there are other products on the market. Edex?
Yeah, Edex is another.
Does that come in a mixable syringe?
The Edex is another good option that you may have. Well, I think that one does come in a mixable syringe that you can mix together and inject that. Dr. Pearce, are you using Edex out of your practice at all? No? Okay. I can get the correct answer for you on that, but basically Caverject and Edex are the name brands for these different treatments, the compounds that I was discussing here today. So
They're similar ingredients, right?
Right. Yes, basically the same mechanism. So, he had a question as well.
After radiation treatment, your motivations are...
People can't hear you back, sir.
Yes, after going through radiation...
Talk into the mic.
Speak to the shop floor.
After going through the radiation treatment for cancer, I find that my motivations were way off. Now, all of these things that you're suggesting would take care of that. The radiation didn't kill everything, did it?
Well, when you say motivation, you mean desire to have intercourse?
Yeah.
Yeah. So that's something that you can discuss with your doctor, because there are some recent articles that state that you can possibly, under certain criteria, start incorporating testosterone again. So that's something that you'll have to talk to your doctor about. But there's other over-the-counter sort of treatments that can help with your desire, and I can go over the exact items with you privately after this. But
I think I'd like to address a little bit more directly than his question, I think. You don't have to have desire to use these injectable medications. You can use them without the desire, and they will work.
yeah, and
Is
especially
that your question?
especially the vacuum device. You know, I mean, you could be watching the football game and get an erection in 5 minutes. I'm serious. I mean, it's like a miracle the way that it works.
Yeah, I just had a follow-up about what he was speaking about.
that it's not necessarily about motivation. It could even be mechanical, and you didn't address it, and that is just because you can get an erection, or even artificially get an erection, does not mean that you can actually have an orgasm or have an ejaculation. There's other muscles involved, and can you address that?
Yeah, and that's a good point, and I'm sure Dr. Pearce can really explain this much further. But as far as getting the erection and having a climax or having an orgasm, you can have an orgasm without an erection. And a lot of people don't know that. But you know, if you're not able to have an erection, it doesn't mean that you can't be engaged in sexual activity with your partner and still have fulfillment. So that's definitely a factor.
I had a question regarding the incontinence devices, the surgically implanted ones, and I was wondering if you could go over the difference in how they're operated between the male sling and the AUS.
So your question again was,
Yeah, how the different devices are operated. It appeared that one would operate without having to operate a valve or anything, it just operates normally, and one might require
right,
touching a valve.
so the male sling is implanted in the body around the urethra, and it actually acts to support the urethra so that it works instantly. So once that's been placed, there's nothing for you to operate. You need to obviously recover from surgery and not do strenuous activities right away. Let everything heal in, of course, like you would with any surgery. But after that point, there are no devices to operate. I didn't really go into the operation of the artificial urinary sphincter, but that does have working parts, much like an inflatable penile prosthesis. There's a small pump that's placed in the scrotum, which the patient will press when they want to urinate. And so you end up using the device 3, 4, 5 times a day just to urinate, and then the sphincter closes on its own. So it's really simple to use, actually. Implanted in some elderly patients that, as long as you have good dexterity, it becomes very much second nature to use that device. Now, the artificial urinary sphincter itself has a higher success rate overall than the male sling does, especially for someone who's leaking quite a bit. But the male sling is ideal for patients who are sort of mild to moderate leakers.
It sounds like the AUS is normally in the on or closed position until
Correct.
unless you
Right.
kind of like air brakes on a truck.
Right, and if it were to ever fail, which is extremely rare, it doesn't fail in the closed position. So it would never cause urinary retention or the inability to urinate. So, and it can be very easily deactivated at any time if someone was to undergo a surgical procedure where they needed a catheter or something along those lines. So it can be switched on and off fairly easily by either the patient or the physician.
Thank you. I did have a question for Russ, and I didn't put you on the spot, but you seem like you're not hesitating to talk about your implant. And I was wondering if you might give some more information.
Well, I don't know what information I can give other than what they've already given. I do have the implant. I didn't know who to go to, so I took the recommendation of a friend of mine that had the implant, and I went all the way to New York. Now that I have the information that I got from the Prostate Forum of Orange County, I know that we have excellent doctors right here. For instance, Dr. Pearce. I won't have to run all the way to New York. But yeah, it was I was in the hospital, I think, overnight, and then I had a hotel room in New York. And I will say one thing about the doctor in New York. He came to my hotel room and visited me, make sure everything was okay. So it was implanted, it's surgically implanted under the skin. I don't know it's there. I have a pump in my scrotum. If I turned right around right now, in about 10 seconds, I could turn around with an erection just like that. And it stays, as the doctors have said, as long as you want it to stay there. You can be reading the Wall Street Journal and it's still going to stay there. It's not going to dissipate on its own. You got to hit the button to let it deflate. And as you can tell right now, I do not have an erection right now. So,
What type do you?
what type? I have the one with the hydraulic pump inserted underneath the bladder, inserted underneath the skin. 3-piece, yeah, 3-piece. You know, if I was going to go, I was going to go first class.
Any generalization of the cost?
You know what, I forget. It was covered by insurance, I'm pretty sure. But I had to pay for hotel rooms and things like that, and I think I was out of pocket about $3,000, but I don't know whether that, I don't know. What is the cost, Dr. Pearce?
It's covered completely by Medicare.
Medicare covered.
In almost every commercial insurance, aside from whatever the deductible will be.
So, short of an HMO, you're covered.
Even covered by HMO.
Even HMOs, huh? Yes.
Any side effects from it or any disadvantages?
Many advantages. I don't know of any disadvantages. I'm way above that 92% of satisfied customers.
Will Obamacare cover it?
Sir?
Will Obamacare cover it?
You know what? I haven't figured that out yet. The question was, would Obamacare cover it? And I'm not real sure how that works. I'm going to wait until after the next 12 days and try and figure that out. Get it done before the next 12 days? Okay. Any other questions here before we break up into individual groups? Okay, again, yes sir, Corky?
The device you talked about going around the world telling the people to use, I didn't understand which one it was.
Oh, you're talking about, where's John Terrio?
Right here.
Oh, he's talking about, what did you talk about using going around the world, John?
I use diapers, pads inside the diapers, so when
It was a kit, right? Here, let me give you the mic. It was a kit that you used, right?
No, wrong way, that's the guy that's talking about the erection.
Okay, sorry, John. You wanted
The
to,
guy that talked about his son knowing it and so forth.
that's John Terrio, only he was talking about incontinence, not erectile dysfunction.
The guy called him on the telephone.
Yeah, they called him, it's incontinence, Corky. Yeah, you bet. Anybody else before we break up? Okay, you guys will just hang around a little bit and let the people that have the more personal questions that are a little shy, like me. Okay, again, thank you very much for our presenters. Please pick up your cups over here and come back and see us again. All of us will hang